Camden, New Jersey sits in the shadow of Philadelphia. It's a city that seems in a constant state of peril. Poverty here is rife. Unemployment is double the national average. Public institutions are in crisis, or, like the local library, simply shuttered. It's officially one of America's most dangerous cities. But Camden may also be the city to help solve one of America's most intractable problems: lowering the cost of healthcare. As a doctor and writer for The New Yorker, I came here to meet the local physician who began to figure it out. It all started 10 years ago with a shooting.
I was working in my house one evening, heard gunshots, then got a call from a neighbor. So I went running down the street. The police had gotten there already. So I ran up and said, you know, I'm a physician, where's the victim? And they all sort of turned around and said, he's over there.
What is the location?
He was laying on his side facing the back tire, and he had a pulse. He wasn't breathing, started rescue breathing. Eventually his pulse stops. So I was just pretty overwhelmed by the whole thing and angry. And
You were angry that they hadn't been even tending to the victim.
You know, I said, why didn't you guys help him? And the police officer said, we didn't want to dislodge the bullet. I mean, it was just a complete blow-off. And I couldn't imagine how we could have reached the point in our society, in this city, where you would just leave a victim lying there in their own blood. He was a Rutgers student, and he was close to graduating. You know, he was one of the wonder kids that make it out of urban communities. And here he was just about to make it out.
Brenner's immediate response was to get involved in police reform. He thought if he could get a hold of crime statistics, he could map hotspots, the places where good policing would make a difference. But the department wasn't interested in helping a local doctor. So he went to another place, one he knew well, the hospital. There, buried in billing records from the ER where violent assaults get treated, he found crime patterns. As he crunched the hospital data, Brenner discovered something totally unexpected: other kinds of hotspots.
It became clear that there were hotspots of everything. There were hotspots by disease, hotspots by patient. There were certain patients who'd been over and over and over going to the emergency room and hospital too much. There were hotspots by zip code and by neighborhood. And so you sit and begin to look through the data, and I'm looking at my patients who are in the data and realizing I had no idea how much healthcare cost. I had no idea how expensive it was, and it was just shocking.
Brenner says the numbers showed that 1% of people living in Camden accounted for 30% of hospital charges, most of those racked up in the emergency room.
So you're compiling all of this information coming from all of the hospitals in the local area.
Compiling massive amounts of data, so a full...
Brenner then turned that raw information into visual information.
So this is a map of the city of Camden, and this is looking at cost data. So the red areas are high-cost hotspots. These are parts of the community where people who have more than $1 million in payments to the hospitals live, and this is over a 5.5-year period.
But Brenner found the majority of the care for chronic diseases, from asthma to cancer to diabetes, was being done in the ER, not a good place to treat chronically ill patients. Treatment was not coordinated, follow-ups were not part of the plan.
It was really obvious in the data that the most expensive people were getting terrible care.
Brenner's big insight was to use his data to target the sickest and most expensive patients in the city. In 2007, supported by small grants from foundations, he put together his team of medical hotspotters.
Hey, Anjanae, it's Kathy Jackson giving you a call from the Coalition. I was wondering if you had a chance to do your blood glucose logs.
The most visible part of the Camden Coalition of Healthcare Providers are these nurses, social workers, and medical assistants.
I think it's also important to show that he was really going all over the state.
Yeah, wherever.
3 years later, his team of troubleshooters has sought out and organized care for more than 300 people.
Make sure we have transportation that's going to be able to accommodate a disability.
When I visited, Kathy Jackson was making a house call to one of her most challenging patients. Under Kathy's care, over the last 6 months, Derek's ER visits have been reduced from 35 to just 2.
See ya.
And Brenner thinks they can do even better if he can get other people from around the city to think like hotspotters.
We've formed this as really a way of beginning to think agency by agency how we can pull together for the most challenging cases. Every month the whole city comes together, frontline providers, social workers, and we do anonymous case discussions at the city level.
Substance abuse initiative.
So when someone like Derek shows up at one of the emergency rooms, they'll call us right away.
Actually, in 2011, he had 2 hospitalizations, and none in April, and only 1 since May. And
So how much has your team been able to lower the costs for this really expensive group of patients?
So we've seen some preliminary results of 40 to 50% reductions in visits and cost. We're now
40 to 50% reduction in costs.
in cost and visits. The other reason that this is so hard is that we actually don't have a good conception of why people go to the hospital and what leads them to get sick. And one of the most profound findings in our work and in the work of people around the country is work that someone else had discovered that we had to rediscover. This is from a paper 15 years ago that no one in the medical world knows about. And it was a very simple study where a physician in California at a huge healthcare system was an obesity researcher. And he began to realize that when he worked with patients, he could get them to lose weight, but that women in particular would lose a whole lot of weight and then gain it back, and he couldn't figure out why. And he started to realize that the women that were gaining the weight back had had sexual abuse, and that as they began to lose weight, they got unwanted attention and gained the weight back. That led him to create a survey called the Adverse Childhood Experience Survey, which are a set of 10 questions that ask you about the horrible things that happen to kids from 0 to 5, about death of a parent, physical abuse, sexual abuse, one parent hitting another, a whole variety of things. And he sent it out, he had the audacity to send it out to 17,000 middle-class people. And 70% of them returned the survey. Can you imagine returning a survey like that? And they agreed to have it connected to their medical records at Kaiser Permanente, a huge medical record system. And to this day, the number of categories of adverse events is the best predictor we found for medical spending, for medical utilization, healthcare utilization, for obesity rates, for substance abuse, for smoking, for alcohol, for out-of-wedlock teen birth, for poorly controlled chronic illness, for IV drug use, for a whole variety of things. So I want to close by describing, the essence of our work is this idea of hotspotting. And it was really an idea taken from Bratton's work in the New York City Police Department. And Bratton realized that you had this expensive resource, the police department, and that a small number of people in the community were committing most of the crimes and were actually the victims of a lot of the crimes. And that the police department was not using themselves strategically as a resource. So he began to use data, mapping, real-time flows of data, and then he restructured the entire management of the police department to respond day by day, week by week to the needs of outliers.